This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
And of the people that present to me, I would say that around 98% of all patients present to me with Hashimoto's, which is the underactive or hypothyroid condition. And I would guess only around 2% with Graves, which is the overactive or hyperthyroid condition.
We know a range of genes or SNPs that cause and contribute to an underlying autoimmune problem. And the big changes, such as viruses or toxicity or hormonal shifts that, for example, pregnancy or perimenopause, menopause, that can cause or trigger an autoimmune condition, whether it's thyroid or any other type of condition.
Often a lot of the hypothyroid symptoms are beginning at the cellular level. So if there's, dysfunction or inflammation in the body, one of the things that often as part of that sort of cell danger response, when the body's, upset about something, it will start to wind back, thyroid hormone production and change the way the thyroid will work. So often people will present with a lot of hypothyroid symptoms without it actually showing, necessarily in their blood work.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists and patients. We look at common clinical presentations through a different lens. It's open, frank and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 3 of Bioconcepts Between Clinical Minds, we look at thyroid health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we continue the conversation on autoimmune thyroid conditions, this time with integrative GPs Dr. Charlotte Middleton and Dr. Aparna Hegde and clinical pharmacist James Jensen. Dr. Charlotte Middleton is an integrative GP based in Canberra. She says the statistics on thyroid disorders are sobering.
When we look at population stats around the world, is that around 10 to 12% of people, mostly women, will develop Hashimoto's in their lifetimes, and most are diagnosed between the ages of 30 to 50 years old. Now, this percentage is rapidly rising, though, for many different reasons, and in some parts of the world, it's actually as high as almost 40%, which is crazy. Graves rates are much lower, with women having a lifetime risk of around 3% and men of around 0.5%. And they are diagnosed most commonly between the ages of 20 and 50 years old. What I do know, because I see it myself when people are presented to me after decades of suffering, is that a lot of people go undiagnosed and truly suffer unnecessarily with symptoms when they shouldn't be.
And why are they going undiagnosed, do you think?
Because, look, the symptoms can be really generalised and, can be put down, I guess, to a number of other conditions. I also don't think people do get tested appropriately.
And you did mention as well that you see the numbers increasing, particularly for Hashimoto's or underactive thyroid. Do you have an idea of why that might be happening?
I think in part there is potentially part of that would be that people are getting tested more, like demanding that they get tested more as people's own awareness around it develops. So I think there's an element of that, but I actually think the majority of that reason is because of poor diets and poor sleep, lack of exercise and increased exposure to toxins in general. And all of this can contribute to gut health, which I will talk about further on. And I think all of that is contributing to not just a rise in autoimmune thyroid conditions, but a rise in autoimmune conditions as a whole.
And just regards to inflammation, and particularly inflammation in the gut, I recently read something where all mental health disorders have some form of gut inflammation as their root cause. Would you say the same for thyroid conditions?
I wouldn't say that it's all. What we know is that there's probably three main factors, I should say, as to why we develop autoimmune disease. One is your genetics, and not a lot you can do about that, unfortunately. We do see autoimmune conditions run in families. I see it frequently. Mum, daughters, sisters, everyone's got, either the same thyroid autoimmune condition, or they've all got related other autoimmune conditions. I see it all the time. So definitely genetics plays a part. We know that different triggers can play a part, food, toxins, all those things that we were spoken about. And then the gut health, definitely reduced gut intestinal permeability definitely contributes. And that is, as I've already spoken to, that sort of persistent and chronic inflammation in the gut wall from certain foods or stress or toxins that can cause the gut lining to become damaged. And that in turn then causes a problem with increases that intestinal permeability. And that means that those irritating molecules or substances can now leach through the gut wall into the bloodstream. And I spoke about leaky gut before. And what we then know is that the body can recognize these in the bloodstream as foreign substances, and what it will do is attack them in a bid to try and excrete them. Now, unfortunately, what can then happen is that in some cases the thyroid cells can actually mimic those pathogenic cells, and the body in this kind of hyper alert state will actually start attacking these cells as well, leading to an autoimmune condition. And in that particular theory, that one's known as molecular mimicry theory, and is one of a number of theories of how autoimmune conditions start, but that's definitely related to that whole sort of persistent chronic inflammation in the gut wall. We know that gluten, the protein in gluten, which is gliadin, closely resembles that of the thyroid gland cells. And so when gliadin breaches the protective barrier of the gut and enters that bloodstream, the immune system tags it for destruction, but the antibodies that then are produced then can go on and actually attack the thyroid tissue as well. So it's fascinating. I find it all fascinating, but it all comes back to optimizing gut health in the first place.
And can Graves turn into Hashimoto's and Hashimoto's into Graves?
It definitely can. In fact, around 15 to 20% of patients with Graves will actually spontaneously develop hypothyroidism from Hashimoto's thyroiditis. And I actually see it quite a lot myself. It's very rare, but not impossible for Hashimoto's to become Graves, so the other way around.
Dr. Aparna Hegde, an integrative GP from Perth, explains the progression of autoimmune thyroid conditions.
So something has to usually trigger the epigenetic shift. There's, we know, a range of genes or SNPs that cause and contribute to an underlying autoimmune problem. And the big changes, such as viruses or toxicity or hormonal shifts that, for example, pregnancy or perimenopause, menopause, that can cause or trigger an autoimmune condition, whether it's thyroid or any other type of condition. But if someone has that underlying genetic profile and there's a lot of things going on, such as leaky gut, the gliadin antibodies, and the hormone shift, how people say stress, majority of what you have is magnified by any hormonal shifts. That's pretty much the same principle, I think. No one really knows what triggers it in terms of autoimmune, but there's definitely an increase of protein release by the body that's abnormal. It sensitizes the body to produce antibodies against these proteins, and that's what then causes that autoimmunity. So the switch gets turned on, essentially.
Why do you feel that Hashimoto's is more common?
So it's more common mainly because of the type of antibodies that are produced. So you've got the thyroid gland, which can produce thyroglobulin, and part of the cell membrane is thyroperoxidase. Those are the two that tend to trigger that Hashimoto's, where the gland becomes destroyed eventually, and the gland doesn't perform as well. Graves tends to be less common because it's the antibody that stimulates the thyroid stimulating hormone receptor on the gland. So the gland ends up producing a lot more thyroid hormone. So you've got, having said that, there are lots of people who have Graves that present with hypothyroidism, which is underactive thyroid as well, that doesn't get picked up as much because we're used to seeing people with Graves that are overactive rather than underactive. So we can't generalise, but I'd say it's mainly because there's a lot more antibodies that can cause Hashimoto's than the Graves.
And so you just said that people who have Graves can be hypothyroid, so have an underactive thyroid. Can you explain that?
So the Graves, you can get there are 3 different types of antibodies that you can get that cause the diagnosis of Graves. They don't all have to be stimulating thyroid release. Some of them can be neutral and some of them can cause destruction of the gland. So ultimately, it depends on whereabouts they are. And people with Hashimoto's for short periods of time can be overactive as well, because as the gland is getting destroyed by the antibodies, there's more thyroid release hormones. So all through the day, they can be either over or under. So you get mixed symptoms from people, and it's very hard to know what is underlying. But that's the reason why in functional medicine we go, okay, let's try and optimize everything. So then we're not having things like low iodine come in and obscure the picture, and make sure that the gut health is healthy. So we're not having the leaky gut contribute to the hyper or hypothyroidism. And we're just focusing on trying to dim the switch, so to speak, of the autoimmunity.
And so when it comes to testing then, if it's such a fluid state, and I guess blood testing is just a snapshot, isn't it?
It is.
So it's just giving you a snapshot in time. So how do you kind of determine where someone's at and how to focus your treatment if it is so fluid?
So it depends on where they present. So I don't test everybody for thyroid disorders. It's the people that I have suspicion of, that they're coming in with results. Usually by the time I see someone, they've already had many blood tests and I can have access to what they've presented with. We can do things like look at thyroglobulin, which is, it's almost like a cancer marker. So people who've had thyroid cancer, we use thyroglobulin as a marker to follow them. If that is high, it means that the body is actually releasing a lot more of the antigen to start with, that's sensitizing the body. So we can try and actually stop the switch being turned on at that stage. So if it's a clinical suspicion, like they have a strong family history of autoimmune disorder, they've got symptoms that I'm thinking could be hypo or hyper. So some people will say, so I'll be, really, really cold 1 minute and really, really hot the next. You have to work out whether that's thyroid or not. Some people will say, I'm gaining weight within the period of a day, like fluid shifts, like a kilo within a period of 2 to 3 hours, and I can see myself blow up. So that then makes me clinically suspicious that it's a transitional flux. But in the end, as I said, because functional medicine is let's optimize everything and try and minimize the insults to the body, it ends up stopping a lot of that violent fluxes.
I know you're dealing with women with perimenopause, so there's that hormonal shift. But what are some of the most common in your patient group, the other triggers for this when that hormonal shift happens? Is it stress? Is it toxins? Is it the genetic predisposition? What's the most common in your group of patients?
So I'd say the most common would be stress. So the burnout stage, and that's because stress can cause things like the leaky gut. And when you are stressed, you're reaching for bad foods, which increase toxicity. You give up on the normal circadian rhythm and sleep restorative function. So I'd say that it's more that than anything else. And it's also compounded by lifestyle. The things you resort to when you are stressed.
James Jensen is a pharmacist and nutritionist based in North Queensland. He agrees stress is an important component in the development of autoimmune thyroid conditions.
When there's a problem at the cellular level, if the body's moved into, I guess, some sort of stress, whether that be emotional stress, physical stress, is there a toxin overload? Is there an infection? Often you see that connection, you'll see quite a few things that happen all at once. So, they might have caught a reactivation of a virus, or they've got a virus that they've caught, something like COVID. They might have their genetic predisposition. They'll often have a poor diet. So, things considering like leaky gut. So we'll often see, 3 or 4 different things or more combined that, I guess, signal to the body that something's not quite right. And then that's where that, I guess, the thyroid will then, or that autoimmune cascade can start to begin.
So I know that the thyroid is complex and you've named a few things that impact it. But in your experience, in your population group, is there anything that kind of stands out to you?
I think the 2 main things that I would see probably as being heavy drivers, other than obviously genetics, diet, I think plays the biggest role and therefore gut health. So, understanding just how important the gut is and how heavily it is influenced by diet. I think the potential overconsumption of, gluten and dairy, they're really big triggers. So we'll often see that people have gut dysfunction. They'll often have that for a really long time before they'll progress to something like Hashimoto's or Graves' disease. So we'll often see, the gut playing up, and then I think we can all understand that there's a lot of stress that we're all under. So I think those 2 are the, big drivers, in my opinion, from certainly in the patient population that I see.
What proportion of patients would you see presenting with a thyroid condition that has progressed to or is an autoimmune condition?
Yeah, what I would say probably the vast majority of the patients that I see would have some level of autoimmunity going on, whether that sort of be, undiagnosed or diagnosed. You commonly see that inflammatory cascade that's going on. Sometimes you even see people that are seronegative for things like Hashimoto's, but definitely have all the symptoms, all the inflammatory markers that sort of make you quite confident that there's some autoimmunity going on.
And that's really important, isn't it? Because there's a lot of people walking around with subclinical hypothyroidism.
Yeah, absolutely. I think once you, sort of get the hang of, talking to these people and you understand what they're suffering, even little things like insulin resistance, elevated cholesterol, when you start to see their, kidney function drop off, so their, glomerular filtration rate, they're all things that are influenced by the thyroid. And they're the little early symptoms or signs that maybe the thyroid isn't coping so well. Even if we're seeing, markers like TSH normal or T4 normal.
I'm interested in that kidney link, actually. So do you see that kidney link often between thyroid and the kidney?
Yeah, I definitely see that when people, I think, potentially not being managed optimally. So if I see that their glomerular filtration rate's dropping and, and they're seemingly on the right dose of their medication, for example, I always start to think, is there more to it? Is there something going on at a cellular level? It's often the people that we're seeing that, they're on medications, but they've got a gut feeling that it's not quite right, or they're, the doctor's telling them that they're Thyroid medication's working perfectly, all the numbers look great, but yet they still have symptoms.
So is that something that you would always look at when you're seeing their EGFR dropping, as well as other things like, gut function, their lipids, etc.?
I won't always see like a change in the kidney function. I mean, often when we see that inflammation, we'll see lots of little things move around and change, but it's something that I definitely look at and consider rather than going, oh, look, this person has a kidney problem. I'll start to consider, who's the chicken, who's the egg? Is it that the thyroid's not quite right? Or is it that, do they have like a kidney problem in isolation? And that's really an important part of getting that sort of comprehensive history. Has there been another reason that they would have, their kidney function compromised? Even like high protein diets, or even those that, for example, do things like they'll exercise first thing in the morning before they'll do their blood tests. You'll often see some of those changes. So obvious things too, like we look at, have they drunk enough water before their test? And if so, we'll retest when they, if they've drunk enough water, we go, well, we know that water's probably not the issue. Is there more to it? Is it the thyroid?
Dr. Charlotte Middleton.
So on the test results, look, a typical picture would be a raised TSH. And I should just, I guess I should just indicate that for me, a TSH of 2.5 and greater can actually be an indicator of an underactive thyroid. I'm well aware that a lot of the ranges go higher than that, the normal ranges. Some say up to 4 or even 5 are okay. But even in some parts of the world, and a lot of endocrinologists now are acknowledging that really an optimal TSH should be at least 2.5 or even 2 and below. What we would also expect to see is a reduced T4 and T3 level, and then you can get the raised thyroid antibodies, which might be one of them or both of them. However, what can be a little bit confusing is that you can sometimes get what we would consider to be a normal TSH, but you see positive antibodies, or you could have a high TSH and normal antibodies. And that's where the thyroid ultrasound might come in handy, as you can sometimes see a change in the appearance of the gland that is consistent with inflammation or thyroiditis. And that's where you still then would suspect that Hashimoto's is the cause of their underactive thyroid.
What is your treatment approach for Hashimoto's? Like, where do you start?
Where do I start? Because honestly, I could spend an entire podcast just talking about the treatment of Hashimoto's, because look, for me, it's not just about treating the symptoms. It is also about trying to find the possible root cause of the illness in the first place. So it's a very detailed and involved and prolonged process. And I tell my patients to be patient with me because, we're in it for the long haul to try and get down to the bottom of it. But look, and in the first instance, if the TSH is just borderline high and perhaps they've maybe got some symptoms, but not all of them, I will really try and investigate further to see if perhaps changing the diet or optimizing gut or liver or adrenal health, or adding vitamins and supplements might be enough just to bring that TSH back down into the normal range and for their symptoms to resolve. So, this could involve doing things like a food sensitivity test, or at the very least, in the first place, just suggesting something like a gluten-free diet. Doing a microbiome test to check for such things as gut inflammation or the level of good and bad bacteria, presence of parasites, worms or fungi, and then adding supplements such as zinc, selenium, iron if deficient, iodine, vitamin D, vitamin C, magnesium, curcumin, which is the concentrated form of turmeric, a lovely potent anti-inflammatory, and good activated B vitamin complex. So some of those food sensitivities that I've, also might focus on are things like sugar, dairy, grains, caffeine, soy, corn. And then to a lesser degree, perhaps the nightshades, eggs, nuts, red meat, cruciferous vegetables, fruits and seeds. So that's just if their TSH is borderline and they don't have a lot of symptoms. If the TSH is really quite high and the patient is very symptomatic, then I often will suggest some form of thyroid hormone therapy, all the while doing all those other things I just spoke about to try and find the root cause. So now that hormone therapy might be the synthetic levothyroxine that we're all familiar with. So, thyroxine, eroxine, Eutroxic or Eltroxin are the typical ones that most people would know out there. You also can get a form of synthetic T3, or it's otherwise known as triiodothyronine. There's also bioidentical T4 or T3 that you can get, and porcine thyroid extract, which is a specific ratio of T4 and T3 dependent on how much of it you use. The latter two of those both require a doctor's script and a compounding pharmacy to make them. I also will focus on liver function and adrenal function, looking at cortisol and DHEA levels and treat those as needed. It's really important to reduce toxic exposure as much as possible. So I advocate using organic house and self-care products wherever possible, and water filters to optimize the condition of the water that you're drinking. And then, optimizing sleep and exercise and reducing stress are all also vital. So it's really about reducing overall body inflammation as much as possible. And everything I've just spoken about will help with that. So as you can see, it's not just about prescribing thyroxine and your job is done. There is so much more that's involved when treating these autoimmune conditions.
Is there any concern about prescribing the T3, or it's just normally what's done mostly to prescribe the T4?
It's very much a case by case. And if I do decide to start T3 as well as T4, I really only started at very small doses. To gauge how the person can react. It is easy adding T3 to push people into a state of what we call over replacement, where they've just got too much thyroid hormone circulating, and it can be more prone, I guess, to causing over replacement symptoms such as, palpitations or shakes or tremor or agitation. So you do have to be careful when using T3 as well, but if you start low, you go slow, you closely monitor the patient, both their clinical symptoms and their bloods, and also, tell them how they might feel or how they might react. I tend to find that we can manage it well. And I often find that a lot of people feel a lot better when they are on both T4 and T3 rather than just T4 alone. It's very much an individual kind of case-by-case basis. And you just have to be monitoring it very closely if you do start it.
Like we spoke about with Hashimoto's, what are those pathology results that you're seeing to make a diagnosis of Graves'?
Yeah, so typically in this case, the TSH will be abnormal. So it often is very suppressed or low. The T4 and T3 will often be high. It might be one or the other or both, and they almost always are above the range. And again, the antibodies will be raised to varying degrees. But most importantly, what you will expect is a rise in that TSH receptor antibody that I spoke about earlier, or the TRAB levels. That's particularly indicative for Graves' disease.
And so when someone has, let's say, a low TSH and let's say they've got some raised receptor antibodies, do you then go straight away into doing an ultrasound to see if there are nodules or there's inflammation there?
I would examine their thyroid gland, and if I've got any concern with the examination, then, definitely I would jump in with that. I tend to often do a baseline thyroid ultrasound where there are abnormalities in the antibodies, because I really want to just make sure what the status of their thyroid gland is early on. So yes, are there nodules, or is it multinodular goiter, or is there any indication of inflammation such as thyroiditis going on in there? So I think it's good practice to have a baseline thyroid ultrasound in these instances.
And what about treatment for Graves'?
Look, again, it can depend, on I guess how symptomatic they are and how abnormal their blood tests are. If they're, if they've got a lot of symptoms and the blood tests are particularly abnormal, I tend to jump in pretty quickly to talk to the patient about starting carbimazole, which may or may not need to involve an endocrinologist. But certainly carbimazole often can be required quite early on to try and help bring those levels back to normal. But at the same time, I will be doing all those other investigations that I've already mentioned previously to, for the possible underlying cause of their autoimmune disease, looking at diet, gut health and vitamins that I will be using concurrently with the carbimazole. And, the idea is that hopefully we will get them off that medication long term. But if they are particularly symptomatic, we do need to try and get those levels back into the normal range as quickly as possible, and carbimazole will definitely help with that.
So when it comes to treatment for Graves, how do you approach the treatment?
So I focus on trying to get all those, potential inflammatory causes down and, as controlled as best as possible. So that's where we'll look at, sleep and stress, what their other hormones are doing. So the sex hormone balance, we'll look at our nutrition as well. So are there foods that we're eating that could be creating extra inflammation? We're looking at gut microbiome, we're looking at, even things like exercise. I guess that whole holistic approach, all those things that contribute to that inflammation, if we can control that, I feel like the immune system generally sorts itself out. And often we'll see people, for example, we'll do a gut cleanse or we'll do something to improve their microbiome. And then all of a sudden they start to feel like they're getting better. And if they are on things, like PTU to bind up that extra free thyroid hormone, we'll see that they might need to come off that because they'll start to feel like they're going too slow. So when we're doing those sorts of things, I'm always getting them to go back and check their levels a lot more regularly than say in a long-term phase, because often when we get those little things right, their body starts to heal and starts to work properly.
And so how often would you recommend the testing in that phase?
Well, again, I'll go off symptoms, but I would say at least every sort of 3 to 4 weeks, I think would be essential.
Yeah.
Especially if someone's in a thyroid storm, because it can go up and down really quite quickly. So, yeah, often, we have people that are really well managed. They might have a really stressful event and then they'll go back into a thyroid storm. Once we can get those stress hormones back under control, we often see a resolution of a lot of those symptoms.
I'm glad you used that term, thyroid storm. What does that mean in a clinical sense?
Well, I guess it happens quite quickly. So you'll have someone that is seemingly moving along really quite nicely. And then whether it be sort of, Graves or Hashimoto's or any of that sort of thyroiditis, you'll see a really rapid progression and like an overt symptomology. So whether it be, down the hypothyroid path or the hyperthyroid path. So, they'll be feeling really, really racy, sweaty, hot, diarrhea, rapid weight loss, loss of appetite. You'll see all those things happening really quickly all at once rather than that sort of slow trickle along.
And what can we do in that situation to help those people in the situation of a thyroid storm when things are happening quickly? What have you used that can support them in that kind of acute situation?
Yeah, so to go back to the basics, I always look at how can we get that inflammation down. So straight away, I'll clean up their diet. If there is some things that have snuck in that, we know they're inflammatory. So, dairy, gluten, wheat products, and just get them to go back to whole foods straight away. I'm really, really cautious about supplementation in thyroid storm. So sometimes, the herbs that we might use to lower stress hormones like, ashwagandha, sometimes that can contribute to thyroid storm. I'm really careful about that. I just stick to the good basics like, magnesium, zinc, vitamin D, just to try and give the body a break and all the key things that it might need, support the adrenals from, good old-fashioned things like, B complex. And I guess I just try and put as much effort on, into the lifestyle things. And, again, if they are in a thyroid storm, I'll often send them straight to their doctor because if the thyroid storm isn't under control from that's where you might need to use those medications while we're working on the root cause because an unchecked thyroid is quite dangerous. And, even something that happened to my sister, she was sort of told, when she was going through a thyroid storm, it'll be okay, it'll eventually resolve. And she ended up with permanent kidney damage. So I guess from personal experience, I'm quite cautious that's where the use of those medications just to control that excess thyroid hormone is really, really beneficial whilst you're working on the underlying causes.
And you mentioned earlier when you started talking about thyroid storm that it could just be a stressful event. Are there any triggers like that you can mention that might trigger someone into a thyroid storm situation?
Yeah, I think most commonly I see stress as probably the biggest driver. Most people don't have too many, major changes all at once, but it might be like a loss of a loved one or something like that. It might be time around uni or something like that, exams that might trigger that. And often you'll see off the back of that stress, that's where their diet will start to go out the window. Some of those lifestyle things that we're talking about, even like training for events, if someone's like training for a big event, they're putting their body under extra stress, so they might be sleeping less, under recovering. So yeah, it's often a collection of a few little things, but it might be the stress that's the main thing that moves them away from doing the normal things that they would.
What advice do you give your patients about stress?
Simple things like getting them to say no to things that they would normally just say yes to. If they're doing something that makes them feel exhausted, then we know that that's probably too much. So yeah, I think it's just having that detailed conversation, and it can be simple things like breathing. Simple breath work goes a really, really long way. I mean, we understand that like nose breathing is really, really important. For example, if they're, snoring or their mouth breathing at night, that's going to reduce their respiration, the oxygenation of the cells, so that nitric oxide becomes a problem. That can move the body into cellular stress, and then therefore you'll see the manifestation of some of those hypothyroid symptoms.
How do you feel about mouth taping?
Yeah, it's something that people are quite nervous about. So firstly, if they do have nasal congestion or things like that, we're going to look at why they would potentially have those issues. So, is there something in their diet? Is there unresolved infections? So we want to address those things first. But if they've got nice clear nasal passages, I recommend mouth taping, because it's a really great way for people to start that nasal breathing, especially overnight. And what I say to people, tape your mouth. If you wake up in the morning and the tape's still there, then you know that you're probably nasal breathing at night. And if you've ripped it off for some reason, you know that you're probably a mouth breather.
Aparna Hegde says care must be taken when supplementing with nutrients for both Hashimoto's and Graves' diseases.
So iodine, we know that the soil in Australia is low. So people these days, they're not having as much seafood, they're not having iodized salt. The government has stopped putting iodine into things. There's less iodine used in dairy production, and you're reaching for your Himalayan pink salt rather than the iodized sea salt, which has led to a lot of borderline, if not low, iodine people. So if we get that up and make sure that's not part of the picture and the trigger for autoimmunity, that's, I think, number one. So for even people who have no gland, iodine's really important for thyroid hormone to work. So to make sure they replete in that is important. The other things that do come into it is iron because of gut health. There is a crossover between the anti-gliadin antibodies and the formation of thyroid antibodies. So the theory is that the leaky gut can contribute to the development of autoimmunity or make that switch even brighter. So getting rid of the leaky gut and making sure the rapidly turnover cells are replete in folic acid, iron, D, and to a certain extent selenium these days is less important because we seem to be getting it in a lot of different supplements, and I'm seeing more people that are high in selenium, but that was actually another thing that is important in thyroid nutritionally.
And is there anything else that you might consider?
So actually with both disorders, Graves and Hashimoto's, there's these jelly-like substances in the subcutaneous tissue which is really hard to move, and the fluid shift is kind of the last thing that goes. So a physical modality of attacking those proteoglycans in the subcutaneous tissue, ordinary lymphatic drainage doesn't seem to work very well. So using some type of additional approach, such as the infrared sauna or, machines that actually target that subcutaneous tissue to get it moving and circulating better, seems to be that extra thing that makes the difference.
In the next episode of Between Clinical Minds, we continue the conversation, this time on post-COVID presentations of thyroiditis, with thyroid specialist naturopath Tara Nelson, integrative doctor Amita Gajar, and a young hypothyroid patient. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.